afterwards. Anyway, thank you so much. It's really so nice to be here. I'm really honored to see this terrific community. Has everybody gotten a seat? Looks like there are 2 more seats up here. It's perfect after the... All right, that's perfect after the restaurant analogy. Then everybody got to come in and have a seat here. Anyway, so I'm really honored, and first I just want to thank everyone who helped bring us here. It's really been a terrific experience. We had a wonderful dinner last night and great interactions leading up to this. And I'm also really honored to speak in conversation with one of my true heroes in this field, Dr. Jones. It's really, really nice. I'm going to talk a little bit about what it means to build community, to teach and address and teach actually students skills in kind of the issues we just heard about, which is how do you teach students to understand what structural racism is in the context of the South? How do you assess that? And really, how do you build that within the context of a university community where people oftentimes feel that, okay, understanding racism is really important, but also I want to get into medical school and I want to go on and have a career or something like that. And so how do you structure that in a way? I've had this kind of unique opportunity in my career. About 5 years ago, I was recruited to Vanderbilt University to direct a center called the Center for Medicine, Health, and Society. Now, before I got to Vanderbilt, MHS was a kind of standard, what's called a medical humanities major. So it was a major that combined sciences with classes in literature and history and the arts, and tried to kind of, in a way, kind of humanize doctors by saying, gosh, medical training is so hard, but let's teach doctors also the more sensitive side of this kind of factor, so let's teach them literature, which I think is really important. As you heard before, I have a master's in poetry, and I've always kept that part of myself alive. But when I got to the major, it became pretty clear to me that what was missing in our major at Vanderbilt were avenues to talk about not just humanizing by people making them more sensitive. These are pre-meds mostly, by teaching them about Chaucer and poetry and things like that, but also to understand the world they live in, and particularly to address factors like race and structural racism, and how do we live in the community, what is justice, how can we address social justice. So we started to grow the major, starting in 2010 when I got there. We hired a number of faculty whose expertise was not so much in the humanities. We do have a number of humanities faculty, but also we hired people along the lines of not so much their discipline, but the topic areas they were working on. We hired people who were working on social justice, on race and health, on racism and health, and we hired across a wide array of faculty. So we hired people from public health and from the humanities, from psychology, from the sciences, and lo and behold, what happened when we started to reframe the major is that we saw a monumental kind of success story. People were saying, gosh, when you make this into these social justice issues, you're going to kill off the major. In fact, we've seen the opposite. This graph actually is not current because we now have 560 majors in the medicine, health, and society program at Vanderbilt. It's the second biggest major now in arts and science on our campus and the fastest growing major. And so we started the changes. We already had about 200, but we've grown the major by over 400 majors a year by adding these social justice components. We've also, because we've hired new faculty, we've increased our course offerings. So all of a sudden we've got more courses on issues like race and health, social justice and health, factors like that people assumed that Vanderbilt students, and particularly Vanderbilt pre-meds, didn't want to learn about, and it turned out that we have waiting lists for all of our classes. Now, we also, because we had this prior curriculum, this is a lot of text, please don't worry about it, but what we did was we organized our curriculum into different concentration areas, because all of a sudden we had all of these students and all of these faculty, and so we organized, again, as you'll see here, not so much by sociology and health or psychology and health or humanities and health. We didn't make it very disciplinary in the framing. Instead, we looked at the issues that we thought were the urgent political issues of the day that students might care about, so things like global health and health inequality and health policies and economy. So we let students choose based on their, in a way, kind of academic and political interests, not so much based on, of course, there are disciplinary courses, but we're very sure that within each concentration area, there are courses that are, some history classes, some humanities classes, some data classes, so that people can really merge disciplines as a way of kind of understanding from multiple points of view really what inequity means. We've also seen a change in the kind of students that come to MHS as a result of expanding our curriculum. So before before, we had lots of pre-meds. It was about 80% pre-meds. But now you can see we've got everything from physicians, humanities scholars, people who are going into health consulting, into law and policy, into public health. So in a way, just by reframing our curriculum, we haven't just increased the number of students, we've broadened, I think, the relevance of the kind of skills that we're teaching, and I think we're seeing that in the kind of students we attract. We've also, over the last couple of years, built a new master's program, a new one-year master's program, and the language we use for the master's program, again, is what's called the social foundations of health. So it's not come here and learn statistics, come here and you learn humanities. It's we're going to teach you about social justice issues using multiple disciplinary perspectives. And here as well, we've seen a rapid rise in the student population. This year, we've actually got 17 students. We started with 2 students. And so simply by reframing along the lines of this area that people didn't think was going to be very important, we've increased our student population. I feel like we've increased our relevance, and we've broadly expanded the kinds of students that we attract. Here's a bit about the master's curriculum if anybody's interested. Here's a quick infomercial. I'll happily talk to you about it afterwards. Now, because we're talking about the South, I would also say that part of the issue, now I love Vanderbilt. I will stand here and defend it. But I would also say that Vanderbilt has a kind of complex that a lot of schools have that aren't Harvard. I don't know what complex Harvard has, but Vanderbilt has this thing of, oh, we're the Harvard of the South. And people keep saying of the Harvard. It's funny, I've taught at a number of schools. Everyone says we are the Harvard of the blank. And at Harvard, did they say like we're the Harvard of the Harvard or something like that? But basically, they kept saying we're the Harvard of the South, and it would emphasize the Harvard part. But the South would be like this: we're the Harvard of the South, like that kind of stuff. People really weren't engaging with, I think, the social context. So part of the issue, aside injustice and dealing with social justice issues in our curriculum, is we also said let's take that up in broader contexts and global contexts. Let's look at injustice at Harvard. No, I'm just kidding. But also we want to look at health in the social context of the South, because that's where we are, and a lot of these issues are incredibly urgent. And so what we did is we started to incorporate recognition of a couple areas in our curriculum. First, we added a series of courses, and we added U.S. South components to a number of the courses. And as you can see here, some of the titles of the courses. These are very interdisciplinary courses taught by demographers and poets and public health scholars. And what we've done is we've kind of increased our teaching and engagement with the local environment. So we've added U.S. South components to a number of the classes, particularly a number of the new classes we're teaching. And actually, this is the first year we've actually added 2 classes in health policy. So we're engaging in kind of the health policies of the U.S. South. And so that's part of what we're growing. Here are some examples of the different kinds of projects we do in our classroom. I teach a class called Men's Health and the Politics of Masculinity. And I teach my students about social justice activism, and we kind of have this big debate in the class. What is women's health activism versus men's health activism? And women's health activism, everybody's like, NFL players wear pink, and breast cancer walk, and all this kind of stuff. And I'll say, like, what's the men's health activism? And it'll be like, prostate mustache, something like that. People have a harder time like kind of figuring out what's mental health activism. And so I say, like, let's start looking at the issues of masculinity around the South. And then I set them loose on the local community, and they do things that are related to the U.S. South. And so we had a big project on the history of the Confederacy in naming buildings at Vanderbilt. We had one on guns in the South, Southern diet. And these are the kind of things that students, I just say, like, okay, the activism skills, go out in the community and tell me a story about the South. One group, this last year did a great, I couldn't believe this, but here are states where corporal punishment is legal versus not legal. It turns out that's a very Southern factor as well. So all these interesting stories about the South started to come up when we started teaching students about men's health activism, and then set them loose and said, okay, go find and engage with a story that's interesting and surprising. A lot of stuff on guns, because that's what I study in my other life. We've also started doing immersion projects in the U.S. South, bringing students out into the local community to tell stories about local monuments, local roads, local highways. How did it get to be that Nashville has a particular level of segregation? Well, let's tell the history of the highway system that divided the black side and the white side of town, factors like that. We've got a class on public health and the built environment. That's a mapping class that teaches about maps of the South and what do we read on maps. It's actually Amy Hamrei's class, who's linked to a number of people in this room. And we've got programming that focuses on the South as well. And so a number of people here were at our conference last year, the Politics of Health in the U.S. South, where we engaged very directly in questions of the U.S. South. So That's one area where we're engaging with racism and health, and really structural racism and health in the South. And I would say from that avenue, a number of questions have come up that we might want to consider in our conversation today, which is what's unique about the South, and even as we were hearing from Dr. Jones before, how do we define terms that seemingly seem transparent and self-evident, terms like race and health and South? Of course we all know what that means. Well, maybe we don't all know what that means. So when we start asking students in our classes or in our colloquia, what is the South? People, it turns out, define the South in very different ways. Is the South a historical designation based on who owned slaves and who didn't? Is it a healthcare system map? Is it a mortality map? And we've really had, I think, a series of debates really about what is the South exactly? Who is involved in the South? And really, I think the debates can, here's a map of health disease rates by county, and you can see that very often the South is the dark region. It's kind of like, you know, I won't make a Rogaine joke here. It's usually the darker region where things are sprouting that aren't exactly good. But in Amory Hamrei's class, for example, she tries to make students make different kinds of maps that aren't just about the negative impacts of mortality. So this is a map that she did in that built environment class that looks at public art in the South, and it turns out you can totally, there's actually more public art in most areas of the South than other places. And so it's kind of like, how can we remap the South in a way that gets away from just pathologizing the South? We also engage with histories of the South, and people, I'm sure, are familiar with this history, but traditional histories of the South very often exclude the kind of stories that are evident if you look at histories of the health in Nashville, for example, where there are very early on black medical colleges and places where patients of color who weren't being treated by white medical systems could go. And so in a way, it's kind of like, which narrative are we going to talk about? And in a way, what we try to address is this very divided mind of the South. The South, by historian C. Van Woodward, was called something that was a divided mind because it very often is two things. And we try to get at that duality in our conversations, which is the story. It really is, I think, illustrated by the story of the who's inside and who's outside the restaurant. There's a tremendous amount of wealth in the South, but there's also so much poverty and neglect. And really, if you just even look at questions of teaching hospitals or health insurance, the South is the center of health insurance industry in this country. The South also has great climate, as we know here, but people have lower activity levels. So there's all these dichotomies of the South that are questions that we try to address and maybe issues that we want to talk about today. So in these ways, I think that what we've done in our curriculum is use the issues of the South as a call to arms for teaching students about social justice, and also about teaching them to be engaged in their local community in a way. It's kind of like these issues seem so big and large, but let's really engage with our local environment. In the last part of what I'm going to say, okay, so this is great. We built this curriculum. We actually trained all these students. We have all these majors coming up. How do we know that they're actually going to learn anything? How can they learn anything about the South? And so for that, we're using a term that myself and other people have been talking about, and Anne mentioned it in my introduction, which is this concept of structural competency. Now, has anybody here heard that term before, besides my friends here? So structural competency is a term that we've been working on, and we've been publishing numerous articles. And the concept of structural competency is one we're trying to impart in our curriculum and in our curricular evaluation. And the concept is basically, how can you tell if students are learning issues of structural racism in relation to the U.S. South in our courses? And so structural competency is a term that I've been writing about with Dorothy Roberts, with Helena Hansen. We've actually started a new kind of activism group, and we're having a kind of structural competency move across medical education. Now, what is structural competency? Structural competency is a term which is training doctors, pre-medical students, pre-health students to discern how a host of issues defined as symptoms, attitudes, diseases, factors that are very often aligned with, the patient of a particular racial or ethnic background don't just represent the impact of race or ethnicity, but also represent attitudes, implications of decisions about matters such as healthcare and food delivery systems, zoning laws, urban and rural infrastructures, et cetera, et cetera. So in a way, what we're trying to say is it's important to pay attention to these structural racism factors in clinical settings. Now, this is in conversation with a rhetoric called cultural competency. How many people here have have heard of cultural competency. So a lot more people here have heard of cultural competency. Cultural competency is, of course, an important term. Cultural competency came out at a moment when not a lot of people in medicine were talking about race. And about 20 or 30 years ago, people started saying, wait a minute, let's start paying attention to the race or ethnicity of the patient. And it led to a system where we've trained doctors to say, you know, Mrs. Smith is a 35-year-old African-American woman who comes to my clinic, that kind of stuff. Now, the issue with cultural competency is that it was a very important move in medical education, but it trained doctors that race and ethnicity were factors that happened in the clinical exam room. That they're factors that happened in the interaction between doctors and patients. Is the doctor attuned to the patient's racial or ethnic background? Can that person engage with that, ask questions about it, be sensitive to it, and factors like that? The problem with that is that when they paid attention so much to somebody's individual racial or ethnic background, the individual factors that led to doctor-patient communication, they would very often forget about factors that were linked to the built environment, the structural environment. So, for example, this book tells these case studies of kind of, you know, Latina woman comes to your office, how do you bridge that cultural divide? But nowhere in the cultural competency case book does it say, how does the Latina woman get her food? If you're prescribing a healthy diet, and there are all these case studies in books, a bit now, Jack Geiger on down have written about this, to say, well, if we're going to prescribe things for medication for patients, if we're going to prescribe a healthy diet, we also have to ask them, where do they get their food? And very often patients of lower income live in food deserts. We don't ask often enough about questions about how do patients pay for their medications, factors like that. These are all structural factors that in clinical conversation get coded as ethnic or racial factors. And so what we're trying to do with structural competency is to say that these cultural competency and individual case narratives, which are, again, very important. You want a doctor who's going to understand you, but they train doctors to listen to individual stories, not structural stories, which, as we heard in the talk before mine, is a core component of how racism actually works in ways that negatively impact health. And so I also think that's important, particularly in the context of the South, because we know from a vast amount of research right now that structural factors are incredibly complex in the South because, to put it long story short, we haven't really invested in structural factors. So if you look at epigenetics and neuroscience and sociology, economics, they're all saying that because of poor neighborhood effects and poverty and factors like that, that these structural factors are particularly urgent in the South. Now, what's also interesting about structural factors is that doctors, in their practice, don't feel like they know what to do about it. And there's a great study by RWJ a couple of years ago where they asked doctors, do you think unmet social needs are leading to worse health for Americans? And 85% of doctors said absolutely. Social factors, health disparities, inequities, racism, these are all factors that are leading to poor health for all Americans, but 85%, the same amount of doctors, also said, I have no idea what to do about that. I'm just trained to talk to patients individually. And so what we're trying to do with structural competency is to address that 85%, to say, yes, there are skills, and you can actually teach those skills. And so we argue in a way that this is a competency that not just medical students and doctors, but pre-med students can learn. And you remember before when I was talking about our curriculum, we are teaching students about the South, we're teaching students about the local environment, but we're also teaching them about the role of structure. How is racism structural in the US South? And in a way, this is also important because these kind of skills are being tested by the new MCAT and factors like that, if you need a thing. So how do we test that? So this is the last part of the talk. I've already told you that we're building a new curriculum. That new curriculum is emphasizing different approaches to race and racism in the context of the South. We're also emphasizing structural awareness in addition to interpersonal kind of cultural awareness. And the question is, how can you assess that? So in conclusion, let me just tell you really quickly about an evaluation instrument that we're developing. We've been basically working on this structural competency tool that we're giving to all of our graduating students and to graduating students who are in the traditional pre-med program. And we're trying to ask them basically, can you tell things about health like questions of socioeconomic status, health infrastructure, health as a socially constructed phenomenon, and inclusion in addition to biologically. So the students don't know, we don't say it quite as overtly to them, but what we say is, here's what we're doing, we're testing students at the end of our curriculum. And I just want to give you a little bit of data, just to finish out my talk, about a study that we're publishing. It's actually coming out in a week and a half in Academic Medicine. It's the first of a couple of publications about this. this. But basically what we're doing is we're testing our students, MHS seniors. Now Vanderbilt, it's like many places, students can major in MHS, in our pre-med, which is an interdisciplinary pre-med, where they get sciences and they also get social context and all the stuff I was talking about before. Or there are strict pre-med class, pre-med track, neuroscience, biology, factors like that, which are much more invested in the science. Of course, both are very important. Both give a particularly important aspect of education. And I might also add, if you're wondering, both kinds of majors have medical school acceptance rates of pretty much exactly the same. So they're all really strong students and they're all getting accepted if they apply to medical school at the same rates. But the question is, what kind of skills does our curriculum teach that other curriculum, the standard curriculum doesn't teach? And I'm just going to give you a few responses, again, from testing all of the seniors. First, we asked students to evaluate their own knowledge of political issues about health economics and health policy. And basically here you can see, here's a graph that assesses, these are the MHS students, and these are the traditional pre-med students, and the questions of relationship between socioeconomic status and health, the knowledge of the healthcare system, knowledge about the Affordable Care Act, and slightly about controversial issues, that our students felt much more confident by self-report about engaging with these issues. We also asked students, what are the most important influences on people's health, like something that's very indebted to the social determinants of health and to questions of structural racism. And I'll just give you, just from this one year, we're doing this for multiple years, but here's what the MHS students looked like. This is a word cloud of the MHS students' responses. They talked about socioeconomics, education, access, environment. This is exactly what we want the students to be saying. So MHS students thought these were the most important influences on people's health. I'm going to show you the pre-meds, but anybody want to guess what was the most important factor for their health? There you go. Overwhelmingly, they said everything was genetic, and we get this again and again. This has been replicated over every single year of our study. So everything was linked to genetics, and not to genetics in the socioeconomic context. Just straight up, it's a genetic difference. So that was for us, and we thought, oh my gosh, it must have been that year. But it turns out every single year we've got the same finding. We were kind of sneaky in the evaluation instrument. We also stole a vignette from a cultural competency casebook. This is from the AAMC Cultural Competency Casebook. And it tells a story of Mrs. Hernandez, a 63-year-old woman who's from Cuba, who goes to the doctor. She only speaks Spanish. She only wants to eat her traditional Cuban food. Now, in a cultural competency context, you would say, well, let's teach the doctor to be more sensitive to Cuban culture, and let's teach him some phrases and teach him some Spanish and things like that. But we were asking to see if students would pick up on the structural aspects of this particular story. And MHS students, when we said, what's the most important thing from this vignette, they would say, well, she may live in a food desert and be able to obtain the fruits and vegetables, and there's things about socialization. So food desert, that's exactly what we want our students to be kind of getting from this, that these differences might be structural as well as cultural. And the pre-med science majors would say things like, since Ms. Hernandez is a foreigner, she may not be able to listen to the American doctor. Now I'm cherry picking the good and the bad ones here, but I'll give you the data next week. We also asked about childhood obesity, what leads to childhood obesity in the South, and we assessed them again through this analysis of structural competency. So we asked them what were the most important factors, access to health care, culture, genetics, delivery, and things like that. And what we saw again was that very slightly the MHS students were less likely to choose individual factors, and they were more likely to choose cultural and structural factors. Here's what those answers looked like. So in asking students about this kind of issue, they would say, the pre-med science majors would say, it's all about culture, it's about individual choices. Individuals dictate their own choices and lifestyles, which is something we saw again and again. And the MHS majors would say things like, well, obesity in the South is because low family income forces parents to work multiple jobs with lack of education and money, and so that changes the diet. So again, a similar kind of answer, but one that takes structural factors and structural racism into account. We also asked them about African American men and heart disease, and why is it that African American men might have higher rates of heart disease, particularly in the US South. And here, by the numbers, it was relatively similar between the two groups in terms of just checking off who talked about structural factors. But if you look at the actual answers, MHS students were much more likely to choose distal factors like healthcare delivery systems and institutional racism and neighborhood effects, and not about cultural differences. Now, the one last part of this analysis was race and ethnicity are not just about minority populations, they're also about majority populations. And so we also had some questions about whiteness, and we sneakily gave a pharmaceutical ad for Effexor from a psychiatric journal, and we showed a white woman holding up a white child. Now, I'll tell you that I did pick out some of the answers where we kind of did say there were some students that kind of picked up on it and said whiteness is the issue and factors like that, but I'm going to skip over the slides. Let me just tell you that the data that is going to come out when we publish it shows that even though we were trying very consciously to teach about it, students had a much harder time identifying structural factors when we were talking about whiteness and not minority populations. It really was like 10% versus like 75%. So talking about whiteness was something that we really had a difficult time imparting. So I guess the take-home point about our curriculum, our interventions, the community, first is that it doesn't, I think the people who hired me were worried that it was going to kill off the program. It's not the death of the program. In fact, there's a need right now because students are coming to college with all of these questions in mind. You can't escape these questions of justice and health and equality, and it's particularly important for people who are entering the sciences and medicine and the healing professions. And so what we found was that our students were much better at reporting these structural factors, these structural determinants of health, particularly when we didn't talk about whiteness, which is an issue that for the next talk I'll maybe theorize a little bit about why it was that they talked about whiteness. And so moving forward, we're doing a bunch of other things. We're trying to train clinicians, use our evaluation tool, and really engage much more with the policy avenues. But I think one of the main points I'm trying to make here is that a lot of times things like cultural competency are thought to be things that are taught just when you're in medical school or just when you're a practicing clinician in the community. But in fact, what we're finding is by reaching students earlier in the educational process, in their pre-med years, you can really address a lot of these implicit bias in ways that really look at some of these bigger issues that are, I feel like, from the perspective of health and racism, the pressing issues of our time. Thank you.
Thank you so much for these fabulously rich food for thought. I guess before kind of opening it up, Camara, do you want to respond to anything that Jonathan has said?
Should I?
Or do people have burning questions?
No, let's do.
Yeah.
Yeah. I would love to hear what you think about this program. Sorry.
I'm on now.
There you go.
Okay. So I am delighted to know about your program and how people are interested. I had three or four things that popped up, So the first, I guess, is for all of, I don't know how to order them. So I'm going to order them this way. When you talk about the structural competence, there's still a possible division that you can make in there that I make. So when I talk about levels of health intervention, I talk about health services. Then I talk about addressing the social determinants of health, like neighborhood context, individual poverty, and the like. And then I talk about addressing the social determinants of equity, which are systems of power that can create a range of context and then differentially distribute different people into those contexts. So that's where you get racism, sexism, and all these other systems of structured inequity. And so I guess, would you find that kind of thing useful? It's sort of like doctors going out there are really thinking of themselves, I use this cliff analogy. Can I just draw it with my hands, like my cliff analogy? So this is how I talk about different levels of health intervention, just to make it clear what I'm talking about. So I think about, somebody just walking along, boom, fall off the edge of a cliff, right? And if that were you or somebody in your family, you'd be delighted to find an ambulance at the bottom of the cliff to speed you under care. But if we were concerned about others, if we're concerned about population health, community health, public health, what else could we put in place besides station lots of ambulances at the bottom of the cliff? So we could have a net halfway down to keep people from falling. That some people might fall through the cracks. You could make it a trampoline halfway down, but even then you'd have maybe lots of people bouncing up and down at functionality, not able to get to the top of the cliff, so you can have a fence. You could move the population away from the edge of the cliff. So labeling that, we can have medical services and tertiary prevention, secondary prevention, first primary prevention, addressing the social determinants of health. But that image of the cliff is insufficient to talk about how health disparities arise. So you have to think about health disparities arising on 3 levels. Differences in quality of care, differences in access to care, differences in underlying exposures and opportunities. And when you start understanding that, we come back to the cliff and recognize that we're really dealing with a 3-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but maybe that ambulance has a flat tire, so it slower goes off in the wrong direction. Or maybe there's no ambulance there at all, nor net nor fence, and usually at those parts of the cliff, the population is being pushed closer to the edge. And there, when you start understanding that, you make a difference between addressing the social determinants of health, like poverty and adverse neighborhood conditions, moving the population away from the edge of the cliff, and addressing those systems of power that are structuring and maintaining a 3-dimensional cliff and differentially distributing resources and populations. So I guess my question to you is that useful? How much do you delve into that?
Yeah, that's wonderful. Thank you. Well, it's so great how we're actually so much on the same page about a lot of this stuff. But it's funny. But so as I mentioned before, we're first we tried to identify what are the resistances to learning about. I'll just call it structural racism. I'm somebody who's very influenced by Stokely Carmichael, so that's where I kind of get my understanding of structure and institutional racism, but other people have come at it in many different ways. As I mentioned before, we tried to hire different scholars of different backgrounds, a disability studies scholar, public health scholar, health economist, and then we would just have, these kind of working meetings where we'd say, how do you define structure? How do you define structure? And that helped us not only devise the evaluation instrument, but also how did we devise our curriculum? Because we wanted to make sure that all the issues that you're talking about health as being linked to services, to determinants, to equity, these were all things that we wanted to make sure people were getting along the way, but also creating those conversations between our faculty made for a lot of kind of cross-pollinization. So we didn't want it to just be, the public health person's the one who's talking about determinants. It was more like we have a writer, a novelist, and he's like, oh yeah, I get what determinants are. And he's doing this whole project on monuments in the South now that looks at determinants through monuments. And so in a way, just putting out those 3 levels of structure has been very, I think, provocative. And the other issue is, I feel like another aspect of why I think paying attention to structure is important is not just that people feel like, it's not really part of the real education that I need to do well on the MCAT and get into medical school. In a way, what we're saying is, here's a worldview that is important in every single class you're going to take. And so if you think that, a lot of times when I went to medical school, for example, we would have a 3-hour module on race, and they would do pre and post testing, and then it's like, okay, go back and learn about heart disease or something like that. But it's like, no, this is part of every story. And so as much as we can, we try to integrate it. And the other thing is, there's obviously a lot of learned helplessness about this particular issue, which is, and I think understandably, doctors will say, I only have 7 minutes with my patient. It's really, what do I do about structural racism when all I have time for is to write a prescription for an antibiotic or something like that? And so I think if we can change that aspect of learned helplessness, that actually structural factors are the result of particular decisions, they happened at particular historical moments, they're the result of policies, and then you start thinking like, oh wait, I'm an internist. What is the AMA doing exactly to address structural racism? Or in psychiatry, what are we doing exactly to address this? In a way, you're trying to do is change the worldview in a bottom-up way that hopefully will change the political engagement of the profession. That's the big.
And actually, we can equip not only your medical students, but everybody in this room with a very important question, which is, how is racism operating here? And I give you that question first of all, because we're all recognizing that racism is not like a cloud or a miasma that you can't get a handle on, but it is a system with identifiable and addressable mechanisms, which I talk about as being in our structures, policies, practices, norms, and values, which are different elements of decision making. So structures are the who, what, when, and where of decision making. Who's at the table and who's not. What's on the agenda, what's not, so that whenever any of you are sitting at a decision-making table, I charge you to look around and say, who is not here? who has an interest in this proceeding, and then it's your job not just to represent their interest, but to find them a way to the table. What is on the agenda and what's not? So as you say, at the AMA or whatever. So that's structures, the who, what, when, and where of decision making. Policies are the written how of decision making. So by their being written, it invites review. So often we're not even aware of policies that govern our actions or what we're in. But also there are policies that are not in place, so we have to get used to looking at the absence of always. That's a very hard discipline, to see the absence of. But to look at policies that aren't there, that could be useful if put in place. Practices and norms are the unwritten how of decision making. Much harder to get a handle on, but that's the shoulder tapping, who gets appointed to a board or whatever like that. And then values are the why. And I used to not even concern myself with values because I thought that was philosophical or religious or something like that, until I recognized, going back to the Gardner's tale, that it was actually the Gardner's initial preference for red over pink that set up the whole situation. And even if we were to compel the gardener to equalize the soil today, if she continued to prefer red over pink going forward, she would continue to privilege red over pink going forward. So we have to address, say, cultural racism, white supremacist ideology, if we're going to set things right in the garden. So this question, how is racism operating here, especially if you're looking at racism in the South, I thought how wonderful to charge students, maybe each of them with a different thing. So how is racism operating here in this area? You guys look at structures, you guys look at policies, you guys look at practices and norms, and you guys look at values, and then come back and at the end of the semester have a book. You know what I'm saying, about how is racism operating in the South, in Nashville on asthma, or whatever. I mean, so that's just something I throw out.
No, we've actually got, if you, I'll send it to you, but
Okay.
our students at the end of the semester come back with these amazing web portfolios that look at appealing, these, and we've had responses, they've changed now the names of some of the buildings at Vanderbilt, which we were very happy about. It's not the Confederate Hall anymore. And so in a way, we've had some real impact. And the other thing I just wanted to point out, because I was kind of going to ask you this question, which is, how do you address the question of helplessness, thinking about that RWJ pool where doctors feel like, gosh, what am I going to do? I'm so pressured. And I want to point out one thing about just the data, and I apologize, I went very quickly through it, but we didn't tell people we were teaching them about structural competency or structural racism. In a way, we weren't trying to be sneaky or anything, but it was just kind of like, here's how actually it's imbued in these vignettes, these stories, these examples, factors like that. And you can see, hopefully, from the examples, the really quick ones I showed, and I'll send the article to anybody who wants to see it in more detail, that actually they became part of the stories that people helped explain day-to-day interactions about particular issues. But I feel like in college it's easy because we have people for a semester, right? And so we can say, here's the beginning and the end. The other nice thing about college is, if you want an A in my class, you might want to become aware of like structural factors. So you have that kind of carrot to dangle. But it's not like I went and said, okay, today's lesson is about structural competency. Instead, we wanted to see how much would that change people's worldview when we're asking them about other stuff. And I think it did. But in the context of clinicians, for example, it does seem like there's so much helplessness about, I'm just trying to get reimbursed and stay alive.
Right. I think the helplessness, not just in the clinical side, but all of us feel sort of helpless, even if we acknowledge structures, because it's like, what can I do? So what can I do? Well, maybe I'll just have my patient walk more or something like that. But we have to recognize that we have professional roles that we can explore more, but we also have roles as citizens. And so, in my cliff analogy, if a physician is trying to be the best ambulance driver that they can be, that's good. We need excellent ambulance drivers. But so often they're so consumed with scooping people up from the bottom of the cliff, they're not even looking up to see whether there is a net or a fence, or thinking about what's moving the population, or what's structuring and maintaining a three-dimensional cliff. I say, be that best ambulance driver, but then out of the job, address your citizenship, and then we have to do it the other way around. That as citizens, the first priority is not about the net or the fence. The first priority is about the inequity and the structuring and maintaining of a three-dimensional cliff, and then the structures and systems that are pushing some people closer to the edge. We need to get that right first, and then when we get the equity piece right, then we can think about moving everybody back, and then we can think about strengthening these other things. So it's sort of citizenship. That's my thing. And so as a physician, you'll be asked by the mayor what you think, or you'll be on boards and stuff like that to use those roles. And it doesn't have to be in your clinical setting. I had something else, 2 other things that I want to just put out there.
Okay, good. I have one more too.
Okay, you go.
No, you go first. You go first. Absolutely.
So I guess,
Then we'll let these other people talk.
yes, we want questions for you. But part of what's hard is that, so I think there are 3 different barriers to achieving health equity in this society. I haven't even defined health equity. I will do that if somebody asks me to do that. But here are the barriers. Or maybe I will. Okay, I'm going to define health equity, then I'm going to talk about the barriers, because it doesn't make sense, right? Okay, so I define health equity as assurance of the conditions for optimal health for all people. Healthy People 2020 actually defines it as attainment of the highest level of health for all people, and I think that that is our goal. But my question is, what if we hit that last Sunday, are we done? And I do not think that health equity is an outcome. I think it's a process. Which process? Assurance, which is actually one of the 3 core functions of public health identified by the Institute of Medicine, along with assessment and policy development. Assurance of what? Of the conditions for optimal health. For whom? For all people. That makes it equity. Achieving health equity requires at least 3 things. Valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. And then, how is health equity related to health disparities? Health disparities will be eliminated when health equity is achieved. So that's the framework. So now, what are the barriers in our nation for achieving health equity? 3 of them. We are ahistorical. I am so happy that you kept an integral in your work is history. We as a nation are ahistorical. We think that the current distribution of advantage and disadvantage is just a happenstance. And we also, being ahistorical makes us think, well, if things were this way when I was born, they're probably going to always be this way, and it makes structures and systems seem like impossible to change. The second big barrier is our narrow focus on the individual. So that means that we have a limited sense of interdependence, limited sense of there, but for the grace of God go I. And when you are narrowly focused on the individual, the structures and systems become invisible. That is the clinical situation right there. And the third huge barrier is our endorsement of the myth of meritocracy. The story that goes something like this: if you work hard, you'll make it. Right? Now, most people who have made it in this country have worked hard. Not everybody who's made it has worked hard, but most people have. But there are many, many, many more people who are working just as hard or harder who will never make it because of an uneven playing field. But if you endorse that myth of meritocracy, you don't even understand the unevenness of the playing field and racism and other systems of structured inequity that are maintaining that. So the fact that you're talking about structural competence is already part of the victory, because for many people, structures and systems are invisible. Comments?
Well, it's funny because the idea of structural competency kind of came to me initially because I was writing a book about the incarceration of Black men with schizophrenia, and looked at all of these prisons. It was a book about mental hospitals that became prisons, and it was so interesting because by the end of the book, it's called Protest Psychosis. By the end of the book, 4 out of 5 people who have serious mental illness and are in a state facility in the United States are in a prison, not in a mental health facility, a hospital. And I would go around and interview people, and they'd say, "Oh my gosh, that's just the way it is. Black men with schizophrenia are violent." They wouldn't say it quite as overtly, but they would say it in one way or another. And then when you track it historically, it's like, actually, that's not the case at all. Actually, it's about which system we funded and how we shifted and who got deinstitutionalized and who got care at home and which diagnoses got deinstitutionalized. So there was this incredibly structural story that you wouldn't know if you just were born yesterday. You'd think, oh my gosh, it's been this way from the beginning of time. Turns out, no, there were specific moments. And I find that there's something very empowering about that, to say, oh my gosh, we go back, and actually it wasn't always this way. And
right.
I'm writing about guns in the South now. Seems like the most intractable issue. It probably is the most intractable issue. But it's the same kind of thing where it's like, no, actually how we got to this level of particular gun violence was the result of decisions that we made. It wasn't
right.
always this way.
So do you all hear that? I mean, so now we need questions from them.
Yeah.
What questions do you have?
Hi, my name is Tarunya, and I'm a student with the School of City and Regional Planning. I think I can speak loudly.
Yeah.
My question is so I'm in city planning, which means that most of the time when we have these conversations, it's almost like preaching to the choir. It's just we add new ways to discuss this stuff with each other. And I also spend a lot of time online talking to people who don't believe any of this stuff happens. Do you have any tips on how to have this conversation with people who won't even come to the table.
And when you say they don't believe which stuff happens.
Oh, that racism exists, or that history matters, or that, we can change things. All of the stuff that you've been saying that I believe. So,
So I'll start. Actually, I understand that people are finding a TED Talk that I've done. So if you Google Camara Jones, C-A-M-A-R-A Jones, TEDx Emory, it's a 2014 TED Talk with 4 of my allegories in it, and people are finding that is a good way to start conversations. Also, just a little 4-page paper that includes my Gardener's Tale, which you can also Google Camara Jones Gardener's Tale. It's just 2 pages front and back. People have said that, like maybe let's have a brown bag lunch about this at work or whatever, that this is a way to start conversations. But the real thing is for people to get out of their bubbles. So all of us in this room is in our own bubble. We go to school, or we're teaching here, or whatever. And we have some of our bubbles are very thick plexiglass. Well, seems very hard to get out of, and some are thin soap bubble. But all of us, I am included, are in our bubbles. And in these bubbles, we are often very unaware that just across town there are people who are just as kind, funny, generous, hardworking, smart as we are, but who live in very different circumstances. So we need to create opportunities to burst through bubbles. What you're doing with your students in terms of getting them out into community, what's happening at the Morehouse School of Medicine in terms of our community health course. There are ways for government to say, okay, for half a day every other week, you as an employee need to go and volunteer in a prison or in a senior center or a children's school. Maybe schools can connect across town and share a 7th grade science class or something, but we need to create opportunities for people to break through bubbles, to experience our common humanity. It's sort of like with the open-close sign. People who don't know that there's a 2-sided sign have never been outside. So some of it is also asking, I wonder why more people aren't coming in, right, to have a question, but many people aren't even interested in that question. Or maybe they hear some sound outside, even though it's light inside and dark outside. Maybe they have the excuse they can't see outside, but maybe they hear a sound. Or maybe once in a while, to begin to burst through bubbles, they can't go out and they'll notice the closed sign there, and then they'll start to believe. I talk about that we all have to be interested in the stories of others, which many people are not. We need to believe the stories of others, and then we need to join in the stories of others. But allegory, in my experience, has been useful.
I of course agree. I'll just say I agree with everything you say. But 2 points that I guess I would make just in addition. One is, believe it or not, as somebody who's been studying this for quite a while, it actually is better than it used to be. I mean, we had a presidential debate, which was interesting in all kinds of ways, but we had a presidential candidate talking about implicit bias in the police force in a major debate. This is the result of the bravery of people putting their lives on the line to raise awareness of these particular issues. Ferguson, a lot of people put their lives on the line in incredibly brave ways. It turned out there was a DOJ report, and it turned out everything they were saying about the structure was true and worse in a way. So in a way, that conversation is, believe it or not, better now. There's more awareness. Now that doesn't mean that it's better. Maybe there's more awareness because it's worse. But I remember when I first started when I went to med school, I mean, the way we would learn about issues like this, and I mean, no disrespect to anybody, they were trying, but like they would give us flashcards of the different races, and they would give us a card, and if we went into a room of somebody who was like Asian American, we were supposed to, I kid you not, compliment their ancestors. That was on the card, and it was like and they give you like everybody had a different flashcard, and like it was almost to the point where like if you were like a white guy and you were going into a black patient's room, you'd be like, yo homie, what's up, or something like that. Like it was, and so anyway, like I'm so grateful when I talk to medical students now, like, oh my gosh, we are better off than we used to be, and I'm sure those flashcards were better off than whatever system they had before. So partially it's that there is, I think, more awareness of these issues, and we need to recognize and encourage people who are putting their lives on the line to raise awareness. And the other point is just getting back to one of Dr. Jones' earlier points that, if we're just talking about the capitalist self-interest narrative, structural racism drains this entire system. And I think that point it really does sap the lives, not just the resources, but the lives of everyone. I'll give you a couple examples. One is you look at towns that did or didn't, states that did or didn't expand Medicaid. States that expanded Medicaid everybody's doing better. It's not just the people in the donut hole, it's not lower income people. Actually, it turns out that that system puts more money in the system for everybody. It actually makes for a healthier state. I'm studying guns in the South. I was going to talk about that, but I figured I'd say, here's some uplifting stuff instead. But it's the same kind of thing where towns that are driven by a kind of particular kind of paranoia that are making guns, and I have friends on all sides of this issue, but basically the more guns without any kind of check system or anything like that, the more self-harm there is, particularly among white populations. So there's all these examples now of areas where maybe the decisions that are being made are being driven by a particular kind of anxiety about white privilege that end up sapping the system for everyone.
How do you want to do questions?
You can field the question.
So why don't we go by row? First row, second row, third row. Okay, any more on the first row?
Yeah.
Okay.
I was just going to ask, so I am from Emory's Sociology Department, first year grad student. What suggestions would you have about making ethical decisions as researchers regarding specific questions we're asking and methods of research to avoid voyeuristic research over substantive, meaningful research that's going to help to create the right type of dialogue that we want for progress, for good things?
What's the voyeuristic? What's an example of voyeuristic research?
We were just reading in a class today about a white male researcher going into low-income black communities and studying crime and like learning to talk black in order to be able to participate in the research.
Wow. You want to take that one first?
Yeah, sure. I mean, I was going to make a joke about...
That's an extreme example.
Yeah. No, I mean, I was going to make a joke that I learned Pig Latin. No, but anyway, I won't say that. But I will say that I guess the point, like, think about that. The issue for me with the pharmaceutical advertisement, where students were really well versed, for good reason, with linking health disparities and wealth imbalances and factors like that. But in a way, the problem with that approach, even though we're teaching it and things like that, is that you come to associate disparity with minority populations only, in a way. And it was the same problem with cultural competency, that people would associate, the automatic assumption was like black sickle cell anemia, Jewish Tay-Sachs, whatever, something like that. So in a way, the frames you put around it create these associations. And I think part of the issue about structural awareness is not just about the structures of the patient, it's also about the structures of the doctor. It's also about the structures of privilege. And so in a way, I'm starting to work on whiteness now for exactly this reason, which is that we have a real shortage of language about the other side of the equation. And I think that in a way, understanding, self-reflection, I would say, would be the key for me.
And I would say that anytime any of us wants to do something, if we use those three prerequisites for achieving health equity: valuing all individuals and populations equally, recognizing and rectifying historical injustice, providing resources according to need. Well, that valuing piece would mean that somebody wouldn't just plop themselves into another community, that they would partner with somebody, and hopefully that other community was asking that person to come in and do some work, and then there would be some kind of partnership. If you think of communities as labs as opposed to partners in terms of improving work, I mean, that's the thing. So we have to walk through this world valuing all of us equally. I don't know if that would help, but to have that as a checklist. Okay, and now I realize that I was going to put in a structural thing like that in there. Okay, here, yeah, here and here. Right. Yes, you're Sean.
Okay, sorry. Sean Harrison. I'm at Morehouse School of Medicine, Director of Counseling Services, Psychiatry, and I teach human values to the second year medical students. So I actually have 3 things to say, and I'll try to be very quick, but I'll talk as much as Camara does. Your question about ethics, I don't think that's a voyeuristic thing. At the medical school, we're really careful about our community health because we need to be very, very aware of whether or not we're using communities or not. Because if you go into a community, study them for some reason or another, and then you leave, you get a lot of money because you got a grant for that, but they don't get anything. So a thing to think about is if you're not at the table, then you're on the menu. So if there is going to be equitable research, equitable questions, then everybody has to be around the table. So if everybody looks the same around the table and you're studying someone else, that's doing something else. Helplessness, you asked about helplessness. I've got a gazillion things to say, and I'm not going to say all of them. The human values class, we do the second year students about 9 classes, and you will be there Friday, right? Yes, you will. We talk about culture and racism and white supremacy for the first 4 lectures or so. What's important to me is that we need to all understand that this is a system, and that's what they both have been saying, and I think that's what helps us to be less helpless, is what you said about history. If we know this isn't always the way it was, but somebody made these decisions, but mostly, our first class is about what's your culture and what's mine. Everybody has a very specific culture. You know, somebody may be, mama's Vietnamese and dad is Hmong, or, you know, there's somebody who's Irish and Cuban. So we talk about that first, and I think it's really important for us to know we don't have to all be the same. That's not what we're going for. That's not where we're headed. That's not even what I want. I'm an African-American female. Yes, I am African-American. Both of my parents are black, and my grandparents are black. Now, past that, I really can't speak to that, but then not many of us in here. So I like who I am, and that makes sense. And as human beings, we're pack animals. We tend to group with people who are like us. There's nothing wrong with that. That's not what we're talking about. And I find that when I can get it clear that I'm not talking about what you did to me or your grandfather did to me. I'm talking about the system that I have to operate in like everybody else. It makes a difference. And my students know they have to say their agents of positive social change. So my question to you. Morehouse School of Medicine is a historically black medical school. We have MBH and other programs. And we have white people there. I've wanted to do a white people support group.
Mm-hmm.
Please speak to me about that, because I was kind of told that was socially unacceptable.
What would it address?
I think that I would like to give everybody an opportunity to have a safe place to process what it feels like to be in medical school and to have to grow up. And if you happen to be a white person who has not been in the minority in your life, and you come to Morehouse School of Medicine, one of the bubbles that we have, the water that we don't see that we swim in, is that it's predominantly black cultured. And so it's kind of hard to not be black there. And I want to know what you think about that.
Yeah, well, I mean, you know, the risk, I mean, I think that would be really interesting to talk to people who are white students at Morehouse and ask them, why did you come to medical school here? What are the most...
They all say this is where I'm supposed to be, but I'm the counselor, so I also talk to people individually, and I've had white students say, I'm kind of mad about something, and I go, yeah, you should be like, oh, thank God, I thought it was like, no. So
Yeah.
they have difficulty figuring out where it's okay to be, and I think they need a safe space.
Sure. I mean, you know, the risk, of course, is that there's no such thing as monolithic black culture or white culture. There's no culture. But I do think that having some space where people can openly talk about race and what it means. I mean, I think that point about being white and a minority is really incredibly important.
I think that's what I want to know. Sometimes it's not comfortable to be a minority.
Right. I'm stumbling because I don't know if I'd call it a support group, because that implies that they need support. Maybe, what's that?
Reflection group?
Yeah.
Reflection group?
So something that doesn't imply that,
That something's wrong?
That they're under assault.
yeah.
But I do know that there is something that feels assaultive because they have to be at Morehouse as a minority, and they have to go out and not be back and forth, back and forth. We're not doing it.
It's an
Morehouse is not
opportunity.
doing it.
You could call it a white opportunity discussion group.
Yeah, I like that. I like that.
Because, no, that, by virtue of them being there, they have an opportunity that many white people don't have in this country.
Yeah. White people get to talk about the privilege of being at Morehouse.
Right.
Absolutely. Yes.
Right, and the opportunity to understand our full humanity intimately for 4 years with classmates who they will grow to love and everything. It's an opportunity that many white people do not have because they don't avail themselves of it or they wouldn't even value it.
Look, I mean, talking about race is hard, you know, in any context. Talking about race is hard. You know, our nation struggles with this in a way. So I'm all for more open
That's what I'm
opportunities.
saying, that
Yeah.
I think that if that was an opportunity, then all of our students, when they leave, would be able to have these conversations, because that's what we want them to do.
Yeah.
As well.
I'll say 2 quick things really
Yeah.
quick. First was just, one thing I didn't show from our data, I was talking about the skills, that's why we call it social competency. We also had a bunch of identity questions, like are you less racist, all that kind of stuff. Nobody's identity changed whatsoever. And I realized, like, I'm really cool with that. Like, my job is not to change anybody's identity. In a way, we're instructors, and what we're trying to do is, here's a skill set that you can master, and I don't really care about, I mean, I care about your identity, but I don't care about, like, it's not like anybody would say, oh, you can, read Chaucer and it's going to make you more sensitive or something. We're not trying to change people's identities. It's, if you keep it on the skill level, I think it's important. I know we're out of time, so
I have a process thing. I would like to hear all the questions.
That's what I was going to say.
Of the people.
Final round of questions?
All the questions,
Yeah.
and then we'll just respond to
That's
whatever
exactly
we
what I
can
was going to say.
remember. Maybe everybody who has a question should stand up and walk over there, and then just talk into the mic.
Or just
Something like
say, or
that.
just stand and say
Stay
it.
where they are? Can you see them? Okay, everybody stand up though so we can see you guys. Okay. Nobody else with question? Okay. So.
Yeah, my question, thank you so much. My question is mainly for Dr. Metzl, but certainly welcome your opinion as well. I'll try to talk loud. With respect to cultural competency, it's my understanding that in health professions education, there's sort of been more of a shift towards cultural humility. So less of the idea of having mastery or a definitive understanding of any specific socio-demographic or cultural group, and moving towards lifelong learning. So with respect to structural competency, I'm just curious, have you had any similar conversations about moving towards something like that? And is it important? Is it the same? Is it different?
Yeah.
In thinking about the system's definition of racism, I buy it. I'm a structural race theorist myself, and I really like that we've had a structural shift in health disparities research. But it strikes me that in making that shift, it becomes harder to hold specific people and institutions, organizations, politicians, the government, et cetera, accountable for the injustice that they enact on marginalized bodies. What are the ways in which we could do that? Is it through the court system, or is it going to be through some other mechanism?
I'm a chemistry graduate student, and I mean, it's pretty obvious everywhere throughout our culture, but especially in the STEM field at the higher levels, it's highly overrepresented by white males. There's not a lot of females or other underrepresented minorities. And I think your program's great in terms of approaching the medical sciences. And I was wondering if it would be a feasible model to apply to other undergraduate programs to help people feel more comfortable coming in, which would be, I guess in the cliff analogy, fit into the removing people away from the ledge of the cliff. But as a person who's coming up, like, do you have any recommendations on being, I guess, a good ambulance driver? Because I've known a lot of really intelligent people who don't want to go because it's too, like, it's really, I think it's awkward to be, like, kind of isolated like that for a lot of people. And I mean, I'm afraid that hinders people from really reaching their full potential because they feel like how can you make people fit in and feel more inclusive? I guess the exact opposite of what you're talking about, the way people in Morehouse, except it's permeating our society. I think.
Cherie Davis Faulkner, I'm a member of Psychiatry Alliance here at Georgia Tech in the Economics and Political Arts, and also adjunct professor at times at Spelman and teaching poverty and social justice. The two pieces that I want to say is one, thank you, Jonathan. I appreciate the fact that you've been in spaces kind of in mainstream media, particularly with Harris
Yes.
Justin Smith, I'm a second-year doctoral student in the Department of Behavioral Sciences and Health Education at Morehouse School of Health at Emory. Dr. Jones, it's always great to see you. Dr. Metzl, I miss you from Nerdland.
Sorry?
I miss you from Nerdland.
Okay, yeah, me too.
So my question is, so I'm here with two of my colleagues, and today, actually in our interventions class, we're talking about the macro-social determinants of health, so very relevant to what we're talking about here. And something that we struggle with is that even as public health takes this broader appreciation that, the things that kind of structure health outcomes are structural in nature, our interventions tend to still be at sort of the individual level. So how do we, take this broader perspective and this broader understanding of all the things that have define health and design interventions that are commensurate with sort of the scale? So how do we think about having a structural analysis, but also applying that to developing structural interventions? Because, as a researcher, if I'm applying to a grant to the NIH, they're probably not going to fund me to dismantle racism, but that's what I want to do. So, how do we kind of think about that from the vantage point of being, up-and-coming researchers that are interested in these types of things?
There was still one more?
Hi, I'm a pre-med bioanalytic speaking here today, and as a pre-med, I kind of feel a play in the position in that the health nature you were talking about. One of the main issues, basically, how does understanding of structural awareness and structural competency influence that small 7-minute time frame you have? Like, I understand that a lot of internists or practitioners have a long time to build a relationship with their patients, but a lot of times when you specialize, you only have that 7 minutes to talk to them. How does being structurally competent influence patient outcomes or have a measurable difference in how well you perform as a physician?
And there's a woman in the back who had her hand up. No? Okay. All
I
right.
have a question.
Oh.
Hi, Kimberly Jackson. I'm a professor of biochemistry at Spelman College, and I teach race and genetics. One of the questions I have for Jonathan is around, you teach this course on structural competency, but do the students put what they learn into action, into the community? So for instance, do they write policy? Do they send it to the DOJ? Do they create gardens for food insecurity? I'm just wondering, how do you work with the community?
So, you want to go first? So I just have a note about each of the questions. So on cultural humility, which actually gets, I think, around to two questions. Going from cultural competence to cultural humility, you're at structural competence. I would say that in the exam room or anywhere that acknowledging racism and other systems of structured inequity is the first competence that we need. I mean, that instead of trying to say, I understand your culture and that you like to eat this or that, or I should say that by acknowledging I understand the system that we're in, that is a communication of respect that will open up a lot of doors. I sometimes think that if clinicians, anytime you sit on a bus or on an airplane or anything, if you just talk to the person next to you for 3 minutes, you will find at least one point of commonality. I don't know if you guys have tried that, but it's true. What if the physician, sometimes physicians see a patient and say, oh, that reminds me of my mom or my dad or my wife or something like that, and they feel an immediate connection. And sometimes they walk in and it doesn't remind them of anybody in their circle, right? But if we were to spend some time identifying those points of commonality as the first thing, that is the first signal of respect, and then acknowledging the existence of racism. I don't know how I'm telling you to do it, depends on what the patient is, but acknowledging that it's something that's real is another thing. So the question about, okay, we understand racism as a system, now who's going to be accountable, right? Part of what I wrote here as an answer was that part of it is going to be through these levers. How is racism operating here? Well, if you identify that it's operating because of how people get named to the school board or something like that, then you intervene there. So it's not really an accountability thing, but it's a leverage. How do you impact? But a really big thing that we have to address still in some parts of the law is intent and the importance of intent. I don't know why I wrote that here in response to your question, but to the extent that, say if you're trying to address discrimination and you have to show intent versus showing disparate impact, it's a whole different thing. So when you're talking about systems and you're saying, well, how can I hold somebody individually accountable? We need to change the law so that disparate impact is an accountability measure that is indictable or actionable or something like that. So that's my thinking there. Chemistry major, mostly white males, inclusion. So my idea there was, in the same way that cluster hires can bolster a program, cluster admissions or cluster anything can make people feel comfortable. They don't all have to be friends or even work together, but just seeing people across the room. So when I was at the Harvard School of Public Health teaching, I left and then the next black person came in and they got my office. Then they left and then the new black person came in and they got my office. And by the time that happened 3 times, I was like, oh, is this the black office at the Harvard School of Public Health, right? So that's a problem. At Levi Watkins, who went through Vanderbilt, but he was at Johns Hopkins. The way he got black people to start applying to the Johns Hopkins School of Medicine was he recruited 13 and then he lied to each of those 13 who were accepted and said that all the other 12 were coming and he got a class of 13, whereas he used to have classes. So that is the strategy, right? Nobody wants to be trying to battle it alone, but we can do it in just a few. Okay. How to take narratives closer to the resident, how to get to the people, what about gentrification, and all of that. So, so we have to have some of these conversations. I think, so I don't know, I've had an idea about a national campaign against racism where we actually train people up in some of my storytelling and in other things too, data collection and all, and then we speak with police officers and teachers, but also community people. I don't know what the National Center for Civil and Human Rights is doing in that regard. They used to have some narratives, but I think that we need to, maybe in sororities or fraternities, we need to articulate that we need to have a national, not only conversation on racism, but campaign against racism. And if we push that forward and then ask every organization to take some piece, that might be a way. The macro social determinants of health, interventions at individual level. What is this? Interventions at individual level.
So I need to think about finding how to develop interventions that incorporate this sort of structural analysis.
How do you really do it? In communities or whatever. Through policy. So how do you get policy? You get more people involved in the policy making process. So you have a community calendar of decision making. When is the school board meeting and what's on their agenda? When is the city council meeting and what's on their agenda and what's not on their agenda? You know, when is the legislative session in and what's being discussed? So we need to all take up our citizenship role, I say. It's not for other people to do for us. And we need to run more people for office and we need to do all of that, but it's about the mechanisms of decision making and having that top of mind. Then I saw, oh my gosh, I have no idea. Money in ambulances, investment in communities over Germany. Here, why don't you go and then I'll figure out what else.
Okay, sure. Oh, well, if you don't mind, I'll run through the list also. So the first question, I think the person left, but I thought it was a great question about the link to the shift from cultural competency to cultural humility, and the idea that basically you don't know anything about somebody else's culture. And I will say that I find that idea to be incredibly useful, and it's actually very central to what we're doing. Now, if you think about cultural competency, for people who've tracked medical education, for example, there's now a booklet of all the stuff you're supposed to be competent in. And I mean, I'm sure it's like, if you're a surgeon, I really want you to be competent in an appendectomy and in listening to my heart and stuff like that. You should definitely know how to do that. But then, it's not like, oh man, I never saw one of these before. Is the appendix, is that socially constructed or something? I don't want you as my doctor. I agree with that. But the idea of competency in this context is in a way a challenge. It's very slightly tongue-in-cheek, not to discount everything I've been talking about here. But if you look at the list of competencies in the medical education manual, it's like religious competency, gender competency, cultural competency, all these kind of things. And in a way, nobody, the best religion scholar in the world is not going to ever say, I'm totally competent. Religion, I got it right here. It's in this particular box or something like that. And it's the same thing with structure. So in the structural competency article that Helen and I wrote. We said the most important skill of cultural competency is to realize the strengths and limitations of medical expertise. The doctors can do this kind of thing, but if they're going to see symptoms as being the result of upstream factors that have to do with policies and food distribution networks and other kinds of factors, that in a way you're not going to be competent. We have to realize is medical knowledge is one contributor to a conversation, but there are many contributors to this conversation. Now, I'm going to link this to the very last question, because we had some students that took us pretty seriously about this. We were teaching a module on food deserts, and afterwards or now, I don't care if you use your phone or anything like that, but we were talking about food deserts, and some of our pre-med said, well, let's look at food deserts in Nashville. And I know the idea of food desert is, complicated and contested or anything like that, but they started kind of exploring this, and then they said, wait, how can we intervene? Well, it turns out our pre-med education didn't teach us about this. So they went and they got some business students, they got some urban planning students, and they built this thing called Nashville Mobile Markets, which has been piloted in Nashville and now is going to be in 16 cities around the country. But it's a student-driven organization that rents refrigerated food trucks in partnership with local. So they went around. They said, "Oh, what kind of food do people like to eat? What kind of cooking do you do?" They have all these partners in churches and stuff like that. They realized, like, gosh, here's what medicine contributed to this conversation, and here's all the other stuff that we could only know through alliance building in a way. And so, in a way, it's to me that one of the best examples of this is that our students looked and they realized they didn't just realize, oh, there's a food desert. That's a term I know from my sociology class. They realized, man, I don't know what it means to get food into a food desert. And so it led to a question. I hope that that's what people would take away from it is it's always a continual questioning process about the strengths and the limitations of biomedical knowledge, that in a way, to be a good doctor, and that's part of what we argue, you have to know what health economists do, what policymakers do, what social workers do, what humanists do. And in a way, we live in a moment where there's so much knowledge all over the place. This is a moment of alliance, and medical knowledge really needs to be more humble, but also, competent in its incompetency, realizing that it really needs to create these alliances. Who is held accountable? That's such an interesting question, because of course I would answer that question historically in a particular way, because in a way I think that it gets back to what I was saying before, that in a way I feel like paying attention to structure links more to accountability, because you can ask questions like, where's the funding coming from for this? What are the policies that led to this? It's not like we're going to change people's attitudes. And so I do feel like paying attention, it's not just that it's accountability, it's also mutability. That things, when you pay attention to things structurally, they can change, and you know the mechanisms through which they can change. The question about chemistry and the STEM model, like Dr. Jones, I'm trying to build a toolkit. Part of the toolkit is our curriculum, the lessons of our curriculum. I know that that's a resource issue that we have at Vanderbilt and Meharry that other people don't. But what we're trying to do is create, we're building syllabi, we're building lessons plans, we're building the evaluation instrument, which we're sharing around with people, stuff like that. So I think this question of let's share resources and create a kind of knowledge base is, I think, where we're at with that. Man, that's really hard about that question of how to get people involved. I'll give you the good answer and the cynical answer. I'll give you the cynical answer first. The Affordable Care Act, I spend a lot of time thinking about the Affordable Care Act these days. What worked, what didn't work, how did we get here, what could have been done differently, and stuff like that. And it's kind of linked to, this is all before your guys' time, but there was an election like about 12 years ago where the guy who was running for the Republican president named Bush kept saying, I'm only gonna whatever for the top 1% of wage earners or something like that. And everybody who heard it thought they were in the top 1%. Like 80% of the country thought they were in the top 1% of the wage earners. They all kind of wanted to identify with that. Now flip to the Obamacare debate, and Obama said we have an ethical responsibility to help support people at the lower end of the income scale. In a way, we need to close the dot hole. This is what societies do. And I don't know. The question is, I'm just playing with this, but human nature, how did that argument play out? In other words, would he have been better off by saying, here's what all you guys are going to get from the Affordable Care Act. You're going to get cheaper prescriptions, and you're going to get more access, and you're going to get all this stuff. Here's what's in it for you. Oh, and also, we're going to help out poor people because that's our ethical responsibility. So in a way, how do you get people to tie in? And I guess that's really an open question. Do you get them to tie in by ethical imperative? Do you link your intervention to something that is in their own self-interest or their idea of their self-interest? And I don't know. I mean, I'm a fan of the Affordable Care Act, but I also think that, maybe that would have been a framing that might have overcome some of these barriers. Who particularly knows? If everybody could have said, it's not just about the donut hole, it's also about, oh
Me.
gosh, it's about me. It's about me. And in a way, I think that's a buy-in that I can be critical of people like that, but I'm sure I do that in my own choices too. So I think that's a particular issue. The question of analysis and how we do this in different fields and how does it influence doctor-patient interactions. I guess this is just the last point I'll say, because I thought the last couple of questions were kind of going with the same way. Again, I think that I'm very sympathetic to doctors who have 7 minutes of time and they really want to fix somebody's, kidney or hypertension or something. Like, of course that's really important. The two-part answer I would give is, one, when you start to see this as in a framework of your own humility about structural factors, it starts to influence your worldview in a way. But also, this is a particular challenge for the politics of medicine. Beside the American Public Health Association, I feel like the silence of many of the medical boards about arguing for social justice factors, and of course it's true, they're understandable, there are many conservative and liberal people, there's things like that, but I'm kind of aiming for, let's think about how we can change the politics of the AMA and the APA and structures like that.
All right, and Camara, just so you know, we have 2 minutes.
Yeah, this question about why are all of our interventions at the individual when we recognize structural factors, some of us, people have figured out how to make money at the individual level. There's a lot of money to be made in ambulances, right? And we have such a narrow focus on the individual that we think of health as an individual matter. When somebody falls off a cliff, we don't think about community health or the health of society. So that's part of it. What could we do if we made investment in communities, sustained investment in communities over at least one generation, over at least 20 years, we would see something. That's how you enrich the soil, the poor rocky soil. You can't just put a little bit over there and then evaluate it in 3 years. So we have to have the belief that that pink seed is equal potential. We have to value all the seed equally. Then we need to make that investment over a generation to see the input. When will we have the political will to do that? Maybe when we understand that our garden is not beautiful, and if there's a prize to be given, if there's a judging going along, our garden is not going to make it, because even though the red flowers look beautiful, the pink flowers make the whole garden not as good as it could be. So.
Excellent. That's a good note to end on. Let's thank our speakers.